Imagine this for a moment. You step into a consultation. You're alone with a patient, and she looks incredibly anxious, and she shares something difficult. She tells you that the person waiting for her, just outside the door, her partner, is controlling every single part of her life.
Right.
The coercive behavior is getting worse, and she mentions they have a toddler at home. Then she looks you right in the eye, and her voice is barely a whisper, and she just pleads. You are the only person I've told. Please, you absolutely cannot tell anyone.
And that exact moment, that's where patient trust crashes right into professional duty. It's probably one of the most high-stakes scenarios any of us can face.
It really is.
You're holding this incredibly confidential information, but you know the safety of an adult and a child is just hanging in the balance.
And navigating that exact intersection, trust, safety, and our legal duties is exactly what we're here to master today. Welcome to the Deep Dive. This deep dive is designed to be your professional shortcut. We're going to be distilling all the crucial UK statutory guidance, so that's the Domestic Abuse Act 2021, NICE pathways, and then the essential risk tools like DASH and MARAC.
And we're giving you the framework, the professional must-dos, and just as importantly, the must-nots.
Exactly.
The source material we're drawing on is, it's highly structured for a reason, because the decisions you have to make in that room have to be rapid, they have to be reasoned, and they have to be perfectly aligned with what the GMC expects.
Right.
So if you can internalize the core mindset, you'll always default to the safe action. And that mindset is actually quite simple. It's believe and validate, act to make safe, assess the risk with dash, share information lawfully, and then refer early to the specialists. So an IDVA or MARAC, and then document everything.
That's the foundation.
That is the foundation of best practice.
Okay, let's unpack that then, starting right at the beginning with definitions. The UK legal definition of domestic abuse is, well, it's far broader than what many people might think, isn't it?
It is, and that breadth is absolutely key for us to be able to identify it. The Domestic Abuse Act 2021 defines it as abusive behavior between people age 16 or over who are personally connected.
And it covers so much.
It's designed to capture the whole spectrum: physical, sexual, violent, controlling or coercive, psychological, emotional, and economic abuse.
I want to pause on that one.
Yeah.
Economic abuse.
Yeah.
That's one that I think practitioners can sometimes miss. What does that actually look like in practice?
It's so prevalent, and it's a huge red flag because it completely destroys a person's independence. It traps them.
Right.
So practically, it could be demanding access to their bank account, taking control of their benefit payments, stopping them from getting or keeping a job, or even running up debt in their name.
And it leaves no physical marks.
None. But it's incredibly controlling.
Connecting this back to the bigger picture, you mentioned something crucial about children.
Yes, and this is a non-negotiable safeguarding duty. Under the Act, children are explicitly classified as victims if they see, hear, or otherwise experience domestic abuse at home.
So they don't have to be physically harmed themselves.
Not at all. Their mere presence when DA is happening automatically triggers our professional duty to safeguard.
So with that broad definition in mind, what does the GMC actually require from us? What are our non-negotiable duties when someone discloses?
Well, the primary duty is always risk assessment and safety planning. The GMC mandates us to inquire privately. That's the absolute starting point. Then assess the risk with a structured tool, provide clear referral pathways, and crucially, engage in multi-agency working.
Okay.
And the GMC is crystal clear on this. Our duty to disclose information to protect children and prevent serious harm outweighs our duty of confidentiality to the adult patient.
Which brings us right back to that opening scenario.
Yeah.
That moment of disclosure. The patient is distressed. They've shared this huge secret. What is the immediate best practice response?
The very first step, the highest standard of care, is to ensure privacy and then give immediate validation.
Right.
You have to make sure the suspected perpetrator is not in the room, even if that means finding a way to excuse yourself or asking a colleague to occupy the person outside.
And then the validation part.
And then you validate them. And the source material highlights a model phrase, which is so important. Thank you for telling me this is not your fault. We will talk here in private about how to keep you and any children safe.
That validation just seems so critical, doesn't it? To build the trust needed for them to accept any more help.
It's everything.
So what's on the immediate safety checklist after that?
It's all about stabilizing the immediate situation. First, treat any physical injuries, assess their capacity, their immediate danger. You might need to arrange safe transport or even consider police involvement if there's an active threat.
Okay.
But There is a critical pitfall here that we have to be aware of, and it's all about communication.
It's that trap.
Never, and I mean under any circumstances, send letters, text messages, or use any communication that could be intercepted.
Go for it.
Sending something to an unsafe address or a shared phone, it could instantly escalate the risk. You have to confirm a secure way to communicate.
I want to highlight the most common error that happens at this stage. The source material is very clear about the danger of inviting the partner in to mediate or hear both sides. Why is that so universally wrong?
Because domestic abuse isn't about a communication problem that needs mediating. It's about a dynamic of power and control.
Right.
Bringing the perpetrator into that conversation just destroys the victim's trust. It shows you've completely misunderstood the danger, and it increases the immediate threat to them. It's a failure of your primary duty to keep them safe.
So the priority is operational safety and validation, not neutrality. Okay, so once that immediate environment is safe, we need a standard way to measure the risk, and that's where DHH comes in. What exactly is DHH?
DHS stands for domestic abuse, stalking, harassment, and honor-based violence. It's the Safe Lives Common Risk Checklist. It has 24 items.
And why is it so fundamental?
Because it creates a unified risk language that's used across every agency in the UK. Health, police, housing, specialist advocates, they all use it. Its purpose is to triage cases and identify those at high risk of serious harm or homicide.
So it's the common language that gets everyone coordinated. If we look at the DIH assessment, what are the really urgent, high-risk red flags? The things that require immediate action, even if the total score isn't that high?
There are definitely a few non-negotiable red flags that, they just bypass the scoring system and demand immediate escalation. And the most urgent one is non-fatal strangulation, or NFS.
This is so much more than just a momentary act of violence, isn't it?
It has profound implications. NFS must be treated as a medical and a safeguarding emergency. Clinically, it's a huge red flag for severe risk, and it's one of the strongest known predictors for future homicide. So even if the patient seems fine, they need an urgent clinical assessment. We're talking potential airway injury, neurological damage, maybe even imaging, because symptoms can be delayed. And in a safeguarding sense, it shows the perpetrator is willing to take a potentially lethal action.
That clinical urgency is such a key detail. What are the other red flags that signal that kind of severe risk?
Well, any use of weapons or explicit threats to kill, obviously. And then two major contextual factors: pregnancy and separation.
Okay, why those two?
They are periods of sharply increased vulnerability when the risk of violence often escalates dramatically. So if the victim is pregnant or if they've recently tried to leave, that assessment has to be escalated immediately.
And children, as we said.
And as we said, children in the household always mandate a safeguarding referral. Failing to use the DHH structure or ignoring these red flags is a severe professional failing.
So if DHH or these red flags identify the patient as high risk, what's the ultimate protective mechanism? Where does this escalation go?
A high-risk finding mandates an immediate referral to MARC. That's the Multi-Agency Risk Assessment Conference.
And what is MAR?
It's not a police procedure. It's a vital scheduled meeting. It brings together health, social services, police, housing, probation, everyone, to coordinate a joint safety plan for that specific victim. It ensures all the agencies are synchronized.
So it's about making sure that safety net is cast as wide and as thick as possible.
Precisely.
And who is the patient's key advocate during all this?
That would be the IDVA, the Independent Domestic Violence Advocate.
Right.
The IDVA is their specialist, dedicated resource. They're the expert support for the patient. They can attend MAR-HIC on their behalf, and they navigate all the complex referral pathways. Getting an IDVA involved should be one of the first things you do once high risk is confirmed.
Okay, let's try and solidify this framework for everyone listening. If we put all those actions into a clear stepwise process, what does that look like?
It's a pretty clean sequence, actually. First action: see the patient privately and validate their disclosure.
Always first.
Next action: do the immediate safety check, and then assess fully using the DSH checklist, flagging any of those red flags we talked about, like NFS or pregnancy.
Okay.
And then the final action is to refer and share information lawfully. So that's an IDVA for specialist support, MARAC if it's high risk, and safeguarding if children are involved.
Now we get to the hardest part of the equation, I think: confidentiality. Because the patient often begs us to keep silent, but we have this overriding duty to safety. When exactly does the GMC allow us to lawfully break that confidence?
This is the real crux of GMC compliance, isn't it? While confidentiality is a core pillar, both the law and the GMC allow us to make a proportionate disclosure when it's necessary to prevent serious harm.
To the patient or others.
Exactly. Or when it's required for safeguarding in the public interest. When you identify high-risk domestic abuse where serious harm is likely, disclosure isn't just permitted, it's professionally mandated.
Even if the victim explicitly says no.
Even if they refuse consent. That duty to prevent serious harm overrides their refusal.
But if we have to share, what are the rules around how we share that information? You can't just send a quick email, can you?
Absolutely not. The key principle is minimum necessary.
Okay.
You share the absolute minimum amount of information required to ensure safety and nothing more. And you must use secure professional channels only. And most importantly, you have to document your complete rationale for the disclosure.
Why is that documentation, that rationale, so critical?
Because your rationale, so why you judge the risk to be serious harm, what you share, with whom you shared it, and when, that is your legal and professional protection. It proves your actions were justified and proportionate. Without it, you are exposed.
And there's a digital trap here too, isn't there, with online patient portals?
A huge one. With patients now having access to their records online, we have to be so careful about what we write in visible notes.
That's a massive hidden risk.
It is. You have to avoid writing identifiable notes or warnings like DA query or details about the perpetrator in any summary that they might be able to see on a shared device. If you must document those sensitive details, they have to go in secure sections, only accessible to clinical staff or specific safeguarding teams. Security has to be part of your documentation practice now.
That's such a comprehensive framework. To help everyone internalize this whole process, the source material introduces a really helpful memory aid.
Yes, for a quick internal checklist, the Safe Home Mnemonic is really effective. It just maps out the whole process.
So walk us through it.
It's screen privately, acknowledge and validate, flag children, evaluate risk with D-H,
Okay.
then help plan, options like an IDVA or the police, MARE if it's high risk, and finally, evidence, which means record absolutely everything.
That's great. It ties it all together perfectly. So before we close, let's just summarize the 3 key professional takeaways that you absolutely have to walk away with from this deep dive.
Okay. First, private inquiry and validation are your mandatory first steps. Making immediate safety paramount is your priority, even over confidentiality.
Number 2.
Second, DISH guides your risk assessment, and you must recognize non-fatal strangulation as an emergency red flag for potential homicide.
And third.
Third, if the risk is high, you must share information minimally but lawfully involving an IDVA and AIR-AFD, and meticulous documentation of your rationale is completely non-negotiable.
Right. Finally, let's go back to the source material for one last provocative thought, one that really separates best practice from a clinical misunderstanding. We talked about the trap of mediation. So why is recommending couples counseling immediately while abuse is ongoing considered such an unsafe action?
It's a severe clinical failure because it fundamentally misunderstands what abuse is. Abuse is not a relationship issue. It's a crime based on power and control.
So what does counseling do in that situation?
Recommending it just gives the perpetrator a brand new tool to exercise that control. It can force the victim to talk about the abuse in front of their abuser, and it can dramatically increase their danger when they get home. It just shows a profound failure to follow that primary mandate. Prioritize safety above everything else.
Internalizing these structured, GMC-aligned steps is just so vital. They ensure you meet the highest standard of professional conduct, and, critically, they are the actions that save lives in real clinical practice. If you do need more of this high-yield, structured guidance for your professional development and situational assessment, be sure to check out the resources over at pastthemsra.com.
Until next time, stay safe and keep applying best practice.